And again, we thank you for being here. This has been great, and we enjoy doing this, and we appreciate your feedback. And like I said, we try to build on what's happening. So what I'm going to do is I'm going to try to build on where therapy is going, and not try to blow anybody away with a bunch of impressive bioscience, but rather what's practical about this stuff and where are we going to go. So hopefully that will be helpful. And also up here, and I want to start off with one of the new things in therapy, because a few years ago we started working to modify immunotherapy, because allergy shots work great. They have a lot of good behind them, but 30 weeks of coming in once a week with people's deductibles and co-pays going up and everything became difficult. And then there became the traffic in Charleston, which, have anybody all noticed that that's a little bit of an issue lately? Anyhow, we have worked to come up with modified regimens that get people to maintenance much quicker, at much less expense, and much more variability in doing that, and it has worked out wonderfully. And so now, what is a great preventative therapy now is much more easily able to be applicable to our patients. So that really has been something that I think has been a good thing, because you want to offer something good, but you knew it had all the issues that made it hard. We've tried to decrease some of those issues, and it's been very successful, and we've had these modifications in place for the last few years. Makes it so much easier for kids in school, for the busy mom, for the person who travels a lot with their business, for our military personnel who have very limited time. So we have many different regimens we can work with them on, and so that's an encouragement. So now what's next? I'm going to wander around. I'm a wanderer sometimes, so if I get too wandery, just say, stay still, okay? So I have to say this. I am a paid consultant for Regeneron, and I'll get into that in a minute. Tiotropium bromide, or Spiriva. Remember, this has been a very helpful medicine for COPD for a long time. And ipratropium bromide, many of us have used for ages for exacerbation of asthma, and it's really been very helpful. Well, through a company listening and doing all the studies, this has now been approved, and it's approved down to 12 years of age for asthma and in adults with asthma, but they've also done pediatric studies, so there's more coming. And the excitement is, it is really helpful. And as John was just presenting, it's another new tool, or another available tool that at least has been vetted so that it can get approved, because there's nothing worse than trying to get things approved that aren't approved, so to speak, right? So off-label just doesn't work. So part of what our thrill is helping get things on label that really are helpful. And Spiriva is safe, it's effective, it's once a day, it's easy, and it can make dramatic change in tolerance and exercise aspects and stability. And so we've been really pleased with that. And so that's good news, and that 12 to 17-year-old age range came in this year, and just last year it was really for adults with asthma. So as you notice, a lot of the asthma medicines are getting approved for COPD, or have been, and now you have all the COPD medicines coming the same way, because the cell types and the patterns, as John was talking about, there's eosinophilic, there's mixed, and then there's more chronic that look more like COPD, and yet it can be what we call kind of an asthmatic who doesn't have the same mechanisms in play or doesn't have the same cell types. And all of that, there's a lot of deep science going on to that, but the new drug development is to try to help with everybody. This one is one that doesn't depend on eosinophilia necessarily, which is different than some of the others we're going to present, okay? So this is one you've had in your closet for a long time, or that you've been using for a while, or variations on the theme. And there are a lot of other medicines coming out now for COPD with once-day long-acting bronchodilators and other forms of LAMAs that are associated with them, and all of those are coming to the realm for COPD, and in the future we may see more work there. Number two is the interleukin-5 antagonists, and these are a group of medicines that's extremely safe. Interleukins, we've been kind of talking about them for years. Actually, back in the old ages, you know, last century when I was in medical school, residency, fellowship, we started talking about interleukins as well. Now they're really coming of age with therapy, and they are dramatically good. But the best thing is, from the standpoint of allergic inflammation, the safety profiles are wonderful. And that's really good, because when you come out with these new biologics and they advertise them on television many times, the trouble is they talk about it, everybody's fluttering around, it's looking great, and then they go through 5 minutes of now, you know, if you might get TB and you might die from an infection and all this kind of stuff, and then you're going, oh my gosh. Well, in the case of eosinophilic mast cell-derived diseases, basically where it's an allergic base, basically it's helminths and something that we don't, a European American, a North American population really isn't going to have a high risk in. In other words, your eosinophilic-derived diseases are not, as they are in Africa, where I've often tried to eliminate GI tract pathogens that are there and the eosinophil counts will be high. I'm not treating allergy. But in this case, we're treating allergy, and so consequently, these things work really well, and that is, malaria is not a major problem here, so that's one thing we don't have to worry about. They are, there's 3 of them that went into development, 2 of them are already on the market, and the 3rd one is coming soon. And like I said, they all 3 show great benefit for asthma, and they become that eosinophilic-derived asthmatic patient who needs more control, but the last thing they need is more oral prednisone or injections of steroid in their hip, and then bone density issues and all that kind of stuff. And these are medicines that are given once monthly, so that makes them fairly reasonable on that standpoint too. John introduced these, and I'm just going to review them quickly. So, and the best part is this like, you know, in the Old Testament when you have the family lines. So this was cousin Mepolizumab, and that was cousin twice removed, I guess. And then Nucala is the trade name. It's a subcutaneous injection every 4 weeks. It's approved for 12 years of age and older. We have incorporated it into our practice. It's been very helpful. And again, for your patients who are hard to control, this may be a reasonable option. All these medicines, though, it's the how much peripheral eosinophilia do you have, and documented at certain levels to get them approved. It reduces severe asthma attacks, ER and hospitalization usage, and prednisone usage. All those are really good things for all of us because that shows better control. So this is one. Number 2 is, again, this is Mepolizumab. That was the second cousin on the other side. This one is now given IV. With hopes to develop and bring to market later a subcutaneous group. As John mentioned, this one had FEV1 change significance. It's for 18 years of age and over. Severe asthma with eosinophilic phenotype, virtually the same kind of indications, but it's IV instead of sub-Q, which makes your choice issues there, one or the other, but they both work very well. And again, we're using both. Okay, then we go to IL-413. Now, I'm on a panel for this, and what we're working on is how to get this to patients, and I'll go into it for a minute. This has been, when we were first talking about interleukins, the ones that are really important for allergy, there's ones that are identified as these things that cause eosinophilic-derived diseases. So IL-4, IL-5, IL-13, probably IL-17, IL-31, there's a number of them that probably play a role. So there, we're impressed enough that was enough science, right? But the point is this is a 413 indicator. What is it coming out for? Atopic dermatitis. It's incredible. It really looks excellent. And we are excited about it, and we've been involved with it for the last few years. And I'm telling you, people with chronic atopic dermatitis, it is the best thing going, and it's not a steroid. I mean, all of us know how much dermatologicals have gone up in price. And number 2 is all of us are worried about HPA suppression when you have a lot of rash and you're chronically putting a topical steroid on it. And sun exposure and heat around here, it can get pretty intense pretty quickly, and then the skin thins out and you have all those other problems with bone density and increasing glucose levels. This is different. It is a subcutaneous injection, and it is, and in our studies that people have been trained to use it at home. So consequently, this is not going to be one of those things where we have to come into the office all the time. It has great promise. It's looking really good. We expect that it will be introduced within a few weeks for the adult population, and the studies on adolescents and children are getting ready to start. Safety profile has been tremendously good, other than some conjunctivitis and as all injectable medicines, a little site irritation. It's been a very, very clean study. So we're excited about this. So this is one that if we waited till next year, it would already be old news because it's going to come out soon. But it is a breakthrough, because what have we had for atopic dermatitis that's new? Well, we just have a brand new topical PDE, which I think Pat talked about. And then we have this, which has been incredibly beneficial and we're excited about. And this, again, what does it do? IL-4 and IL-13 work together to stop signaling or to suppress the signaling of these inflammatory cells to come from where they're stacked up and ready to work to the inflammatory hotspot. So in other words, the eosinophils, probably the mast cells, the basophils, they're all not being called into the inflammatory area. And so consequently, again, it's preventative in that way. So eczema area, the severity index, the itch, oh, this has been amazing. You know, we have so much trouble controlling itch. And it is so amazing when people itch less, they scratch less, and then their rash goes away. But how do we get them there? Well, we put them on Benadryl 4 times a day, and then they try out for the zombie parts in the movies that are done locally, right? Or they fall down steps if they're older. And so consequently, that's not a good option. It doesn't work most of the time anyhow. But when the skin starts to get right, the itching starts to get right. And that's been one of the great things. Quality of life has been just incredible. And they did a great job of looking at the psyche, all this. And I'm really into that. I have a master's in counseling. And I love the fact that the overlying aspects of anxiety, depression, and issues plague food allergy. And they plague skin-related problems that are constantly of difficulty. And there was a huge change in anxiety and depression scales as well. So this has been just a huge benefit for us. And again, injection site reactions and a conjunctivitis in this. This is one of those medicines, like a couple of the other biologics that are out, that may have multiple other indications. The asthma trials are getting close to the end as well. And Aaron presented about EOE, so here you go. The studies are starting on EOE. The theory on EOE really is that EOE is internalized atopic dermatitis. It seems to be reacting to environmental allergens, probably through swallowing or some other kind of mechanism as well. Inflammation, irritation, waxing and waning, all the cell types being called in. And so consequently, those studies and then studies in nasal polyps are all basically lined up and going. So this is one of those things that stay tuned. Let's see what happens. But from the standpoint of allergy and immunology, this is an excellent weapon, and a weapon for some things we haven't had good treatments for. Nasal polyps, EOE, and atopic dermatitis. I mean, we're out there, doing the best we can with what we can, and always feeling like, boy, I wish we had more. So we're excited about the opportunity with that, and I'm excited about this product. And the work up front is also, how do we get it to the patients? And at least that's being attended to, quicker rather than slower as well. So again, FDA approval expected in 2017, and there was actually a FDA bulletin that came out, I think, this week that was saying soon. Peanut allergy treatments. Again, what a dynamic year. Last year, when I was standing before you presenting on food allergy, we had, I think, 4 weeks before this, started our peanut allergy study, right, Marla? It was in December of 2015. And then now we're 1 year in, and we're seeing excellent success. And this is exciting because this is a peanut product where you know how much allergen you're getting, and you can come in as low as 1, 2, or 3 milligrams. And just to give you, one peanut has 250 milligrams of peanut allergen. And so this is a medicinal food, kind of a new category where the same milligrams, I'm getting an antibiotic, so I want 250 milligrams of such and such, where you can, so many milligrams of peanut allergen is being measured out for daily consumption and then gradually increased. So it is a form of oral immunotherapy, and it is working, and the families are following through with it. But the questions are going to be, not only does it work, but now, can we back it off? Can we make it more reasonable? How often do we have to do it? And all those questions will take a number of years, because we're basically we finished year 1 with a little bit of early information that's going with that. But the second thing is every time we bridge over into something like doing double-blind, placebo-controlled challenges on people with peanut histories, we're learning new things. Like, many of our patients don't respond to smaller doses, and maybe they've been without peanut ingestion for years. And so that's where I talked about it could be both good and dangerous, because if somebody ingests a little bit of peanut and knows they had peanut and didn't react, They may justify the fact that, well, now I can eat a whole handful of peanuts, and they may go way over the threshold and create the very problem we're trying to avoid. So the good news is we have been mostly so good at avoiding peanut, but what we haven't been good at is understanding what is really the true natural history of peanut. Now we're able to look at better information from blood sampling, from tissue sampling, and we have better ways to be able to really know the threshold of the allergen that we're giving and which allergens we're giving, because some of the allergens don't create the anaphylactic type reactions, and now we know that as well. So this has just been a brilliant time of really starting to understand more about peanut allergy, and to be honest, getting more information makes it much more variable as to what's going on with different people. But the good news is treatment is already being given under observed status with us and at 50 other sites around the world, and in a few years that may be something we can get pharmaceutically by a prescription. Again, with everything, it's expensive, but boy, oh boy, it's exciting. So this is the orally administered gradual dosing, known quantities of allergen, high rates of desensitization. I mean, seeing blood tests drop, seeing skin tests become negative or go down in size and all that. And again, we're using, if you look at that handout from earlier, the size of the skin test or the level of the blood test or the breakdown of the allergens is going to help us take a first look at that child where you're not sure what the risks are, and then we can do the oral challenge, or we can say, well, nope, don't go there. And being completely negative isn't always necessary. The skin test may be positive, but it still may say it invites us to do a graded oral dose challenge, which may be the better result rather than complete avoidance, okay? So our goal going forward is we don't want to have to treat people for peanut allergy more than necessary, but if we start early and we start right, that may be our best way to actually have less clinically significant peanut allergy, and so that's a great avoidance strategy. So that's the excitement about that. And it doesn't ever stop there. The epicutaneous studies just started recently, and yes, we have those as well. And that is where the peanut allergen has been loaded onto a patch that's about nickel size, and you can see it right there. And it's typically, they started out putting it on the arm, but now they're putting it on the back around the shoulder blades in 4 different areas and moving it around. And it gradually absorbs. And of course, we know Epicutaneous has worked for numerous other medications, and it's a real easy, adaptable thing. And in the initial studies in small groups, they found that the 4 to 11-year-old age group, the absorption and other factors about it, it seemed to be that it was magnified. The benefit was magnified in that age group. So that age group is being moved forward with a large study to see if they can get FDA approval for this approach to be used to treat allergen immunotherapy as well. There was a 50% success rate with 10 times the ingested peanut tolerance at 1 year of the absorbable one. And there was the most significant side effect, again, was mild rash at the site of the absorption, and typically treated or given time that would resolve. Again, there's the age range that it seems to have been best in, and the compliance rate is very high. I mean, in the morning you put on the patch. If the kid's in swim team, you do go to swim team and then you put on the patch later. The compliance rate was high because of its ease. It was easy to take. One of the nuances that's coming out of this, and my patient initially that I presented had everything twisted in it, and so I could go back to it, but the 2 most likely presentations for a food allergy are, number 1, skin, hives, itching, atopic dermatitis, but skin reactions. And number 2, GI, nausea, a sense of reflux, or vomiting, oftentimes projectile. So one of these medicines utilizes the GI tract. The other medicine is using the skin. And it may be that having 2 different mechanisms will help us, because if you have trouble tolerating the GI approach, you've got a backup plan. And if you have trouble tolerating the skin approach, you have an alternative plan. So constantly, that's what's great, to have 2 different treatments going literally side by side through development, both of which may have great benefit. So it's been a really exciting year for things that I think are very clinically applicable, and for all of us, because we're all seeing these patients. And like I said, besides giving them EpiPen and telling them, don't eat anything of this type or whatever. And the great news is egg and milk are already at the point of being ready to go as soon as they, kind of get the peanut thing stayed. And so the same mechanism works, and the allergens being able to lift it in that are good, okay? So that's kind of what's new. A couple other things I will just mention, okay? First thing is the PDE inhibitor that Pat talked about, the phosphodiesterase inhibitor, increases CAMP, and that is going to be available real shortly. That may come into your clinics. Certainly, it's another non-steroid topical use medicine that's safe for children with atopic dermatitis. So we're excited about having a new topical that may work well for us. As with all new topicals, hopefully that'll be affordable as well. And so there you go. Thank you for that. I think we have a group of us now,